In America, the neighborhood pharmacy has always been one of the most familiar stores around. CVS, Walgreens, Rite Aid. It is where you pick up a prescription after a doctor's visit, buy cold medicine or toothpaste, and get a flu shot. But lately, those pharmacies have been disappearing. In 2025, Rite Aid closed every remaining retail store after 63 years in business. A national chain that once operated more than 5,000 locations vanished from American streets after filing for bankruptcy twice in less than 2 years. Walgreens announced in 2024 that it planned to close roughly 1,200 stores over 3 years. CVS closed about 900 stores from 2022 through 2024, then closed another 221 in 2025. Even many stores that remain open do not feel the way they used to. Lines are longer. The pharmacy closes for lunch. Hours are cut because there are not enough people on staff. And when you call, no one seems to pick up. This is bigger than a few companies making bad decisions. Researchers tracked nearly 89,000 U.S. retail pharmacies that operated at some point from 2010 through 2020. By 2021, 29.4% of them had closed. For most of the 2010s, more pharmacies opened than closed. In 2018, that pattern reversed, and it is not because Americans suddenly need less medicine. Nearly 9 in 10 Americans aged 65 and older reported taking prescription medication. U.S. spending on retail prescription drugs rose another 7.9% in 2024, reaching $467 billion. Demand remains enormous, spending keeps rising, yet the places that hand out the medicine are disappearing. So what is going on? To understand it, we have to look at what happens behind the pharmacy counter when money changes hands. At an ordinary store, the basic idea is simple. The store buys a product, sets a price, and sells it. But when insurance is involved, a pharmacy cannot simply name the price it wants. The pharmacy buys medicine from a wholesaler. When a patient presents a prescription, it sends an electronic claim through the patient's drug plan. Within seconds, the system sends back how much the patient owes and how much the pharmacy will be paid. Sitting near the center of that transaction is a company most people have never heard of. A pharmacy benefit manager, or PBM. If you have ever used insurance to fill a prescription in the United States, there is a good chance a PBM helped determine what happened at the counter. That helps explain one of the strangest experiences in American healthcare. Sometimes the same drug is cheaper with a GoodRx coupon than with your insurance card. GoodRx is not insurance. Its coupons show discounted cash prices based on rates negotiated between pharmacies, pharmacy buying groups, and PBMs. One medicine can have an insurance price, a regular cash price, and a coupon price. Even with insurance, you may have to compare all three. PBMs manage prescription benefits for insurers, employers, unions, and Medicare drug plans. They negotiate discounts with drug makers, help build lists of covered drugs, create pharmacy networks, process claims, and negotiate how pharmacies are paid. In theory, this makes sense. Representing millions of patients can give a PBM more bargaining power with drug companies. It also saves insurers from processing every claim themselves. The problem is that this business has become extremely concentrated. In 2023, the 3 largest PBMs processed nearly 80% of all prescriptions filled by U.S. pharmacies. The 6 largest processed more than 90%. The big 3 are CVS Caremark, Express Scripts, and Optum Rx, and they are not just middlemen. CVS Health owns Caremark, CVS Pharmacies, and the insurer Aetna. Cigna owns Express Scripts and affiliated pharmacy businesses. United Health Group owns Optum Rx and its own pharmacy operations. Imagine that one company runs a shopping mall, decides which stores customers may use, decides how much each store gets paid, and also owns a competing store inside the mall. That is the conflict regulators are worried about. PBMs help decide which pharmacies join an insurance network. They can label some locations preferred, giving patients a lower copay there. If a local pharmacy rejects a bad contract, it may be left outside the network. Its regular customers may then move to a chain store or mail-order pharmacy where their copay is lower. But accepting the contract does not always solve the problem. The pharmacy may have already paid a wholesaler for the drug, only to learn that its reimbursement is close to or below the purchase cost. It fills one more prescription but makes almost nothing or loses money. For years, another problem was uncertainty. In Medicare Part D, later adjustments could reduce what a pharmacy kept months after filling a prescription. Beginning in 2024, Medicare required expected pharmacy price concessions to be reflected at the point of sale. That reduced some uncertainty, but it did not guarantee adequate reimbursement. The controversy becomes even sharper when a PBM pays a pharmacy owned by its own parent company. In a 2025 report on specialty generic drugs, the Federal Trade Commission found that the big three PBMs reimbursed their affiliated pharmacies at higher rates than unaffiliated pharmacies on nearly every drug examined. From 2017 through 2022, those affiliated pharmacies generated more than $7.3 billion in dispensing revenue above the drug's estimated acquisition costs. That number does not represent every prescription in America. The study examined 51 specialty generic drugs used for cancer, HIV, multiple sclerosis, and other serious conditions. But it shows what can happen when the referee and one of the players belong to the same company. The PBM industry disputes the FTC's conclusions. It says PBMs reduce costs by negotiating discounts and rebates, and that the FTC used a narrow selection of drugs to distort the broader market. So the problem is not simply that PBMs exist. The deeper problem is concentration. A few companies control most prescription claims, while insurance, benefit management, and pharmacy businesses sit under the same corporate roofs. Much of the money moving between them remains difficult to see. Still, PBMs do not explain everything that happened to Rite Aid, Walgreens, and CVS. America's big drugstore chains were built on a second business model as well. Customers came in for a prescription and also bought shampoo, makeup, snacks, batteries, and greeting cards. Those purchases helped support large stores on expensive corners. More of that shopping moved to Amazon, Walmart, Target, dollar stores, and other retailers that often sold the same products for less. Drugstores still had to pay rent, wages, utilities, and inventory costs for large buildings. Meanwhile, prescription reimbursements and front-of-store sales were under pressure. Rite Aid had even more problems. It carried heavy debt and faced major opioid litigation. When it filed for bankruptcy for the second time in 2025, it still operated about 1,200 stores and served roughly 8 million customers. But with pharmacy margins falling, it could not carry more than $2 billion in debt. Its prescription files and pharmacy assets were divided among competitors including CVS, Walgreens, Albertsons, Kroger, and Giant Eagle. By that fall, its final retail stores had closed. CVS is in a different position. CVS Health is not just a drugstore chain. It also owns Aetna and Caremark. A neighborhood store is only one piece of a company that also earns money from insurance, benefit management, specialty pharmacy, and mail order. So, total healthcare spending can rise even as the number of places a patient can physically visit goes down. The strain is also visible inside the stores that remain. Some chains reduced pharmacy hours, while many locations struggled to retain pharmacists and technicians. The workload kept growing. More prescriptions, vaccinations, phone calls, and insurance problems. In 2023, pharmacy workers at CVS, Walgreens, and other chains staged walkouts over staffing and working conditions. The action became known online as Pharmageddon. Workers said understaffing made it difficult to fill prescriptions safely. Organizers and the companies disagreed over how many stores were affected, but the protests showed how much frustration had built up behind the counter. For patients, the results are familiar. Wait times grow. Calls go unanswered. Some customers move to mail order or another chain. That weakens the store further, leading to more cuts and closures. But a pharmacy closure does not hurt every community equally. In a dense city neighborhood, another pharmacy may be only a few blocks away. In a rural or low-income community, the store that closes may be the last one left. When a Rite Aid in Brunswick County, Virginia, closed in 2025, the entire county was left without a pharmacy. One resident had previously driven about 12 minutes to fill prescriptions. After the closure, the nearest alternatives were roughly 30 minutes away in either direction. For an older person, someone without a car, or a patient managing several medications, that is more than an inconvenience. Places like this are often called pharmacy deserts. A 2025 study estimated that 57.1 million Americans lived in areas without adequate pharmacy access. Another 28.9 million depended on a single keystone pharmacy. One store whose closure would turn their area into a pharmacy desert. Closures have also been more common in predominantly Black and Latino neighborhoods. Independent pharmacies, which are more common in many Black, Latino, and low-income communities, were more than twice as likely to close as chain pharmacies. And when a pharmacy closes, people do not always move smoothly to the next one. A study of more than 3 million adults age 50 and older examined people taking statins, beta blockers, and blood thinners. After a patient's pharmacy closed, medication adherence fell immediately by roughly 6 percentage points compared with similar patients whose pharmacies stayed open. The decline was even larger for people who had used independent pharmacies or lived in areas with fewer alternatives. A pharmacy is not just a place that hands over pills. Pharmacists give vaccines, check drug interactions, work through insurance problems, and provide medicine needed the same day. A pharmacist who knows a regular customer may also notice when a prescription suddenly changes. The company moving fastest into this gap is Amazon. Amazon Pharmacy says it plans to offer same-day prescription delivery in nearly 4,500 U.S. cities and towns by the end of 2026. It also operates PillPack, which sorts medicines by date and time, and it has introduced prescription kiosks at selected One Medical clinics. For someone taking the same medicine every month, delivery can be genuinely convenient. It may also help people who cannot drive long distances. But an app and a delivery van cannot solve every problem. If you need an antibiotic today, if an insurance approval gets stuck, a nearby pharmacist still matters. Delivery may fill part of the gap left by local pharmacies. It may also concentrate even more prescriptions in the hands of a few large platforms. The federal government now treats this as more than a simple change in retail shopping. In 2026, the FTC reached settlement agreements with Express Scripts and Caremark over alleged PBM practices. The proposed orders called for more transparency, separated certain PBM fees from drug list prices, and offered community pharmacies a cost-plus reimbursement option. As of mid-August 2026, the Caremark order still awaited final approval. States have also adopted or considered restrictions on spread pricing, in which a PBM charges a health plan more for a drug than it pays the pharmacy and keeps the difference. But changing the rules does not immediately bring a closed pharmacy back. Rite Aid is gone from American streets. CVS and Walgreens are still reshaping their store networks. Amazon and mail-order pharmacies are growing. America's local pharmacies are not disappearing because people need less medicine. They are disappearing because the money does not necessarily flow to the place that hands the medicine to the patient. As insurers, PBMs, chain pharmacies, and mail-order operations combine inside a few enormous companies, a prescription can be profitable for the system while remaining unprofitable for the local store that fills it. Add online shopping, too many stores in some markets, heavy debt, and chronic staffing problems, and the result appears first on the street. A familiar sign comes down. A prescription is moved farther away. The line at the remaining pharmacy gets longer. The disappearance of the local pharmacy is not just the loss of another store. It is a sign that America's prescription drug system is being rebuilt around a small number of giant healthcare companies and delivery networks.